We move on and hear from Shankar Nazarale and Sudarshan about these third itis, conjunctivitis, keratitis, reasonably well covered. Scleritis is another entity which a lot of people keep confusing. You see whether to give steroids, topical, oral. We'll hear from Sudarshan what he has to tell us. Over to you, Sudarshan. Are you there, Sudarshan?
Good evening, sir. Am I
Yeah,
audible?
yeah, please. Yeah.
Thanks, sir, for including me. It was like quite interesting to hear Sunshila and Rajesh talk about it. It is obviously like very interesting. We've all learned from our UG days about red eye. It used to be one of our favorite questions for all the professors, where they used to keep asking what is the differentials for red eye, conjunctivitis, uveitis, glaucoma, scleritis, and others. So I used to probably think like we can one thing we can afford to miss is conjunctivitis, but not others. But now with especially with non-corona, in corona days, even that seems to be scary. So now we know that even conjunctivitis can be an indicator of an underlying life-threatening disease. But I was feeling ashamed now that being from Chennai, like I didn't know that Chennai or Madras was so big. Like, we used to always keep thinking conjunctivitis, Madras easily like, go take some ampule or some ointment tube there in the medical shop and use it. So Rajesh told us that the conjunctivitis is such a big thing, and Somshila definitely showed us how serious condition keratitis is. Probably it's definitely an emergency that we need to be thinking about. But talking about emergencies in the eye, one thing if we are all very sure about being an emergency in the eye is scleritis. So look at this 35-year-old female who came to us with pain and redness. So, this is a case of a scleritis. We treated with topicals and systemic steroids, and it got okay. But life is not so easy with scleritis as with any other chronic disease. So sometimes it's very recurrent and it aggravates with steroids. And we were talking about using steroids for conjunctivitis and keratitis, and that it shouldn't give a wrong signal. But scleritis is one thing that can lead to the removal of the eyeball itself. So what if it's like this? Then we are very scared. So it's always better to know what you should not miss in a case of scleritis and what you definitely ought to know in any patient who you've already diagnosed as scleritis. So getting to know the ought to know the difference, definitely scleritis and episcleritis. This difference is very important to be known by everyone. It's very important that we don't overtreat episcleritis, but that doesn't mean that we should miss out treating scleritis, because episcleritis gets okay with topical low dose NSAIDs most of the time, and low dose steroids or lubricants. The patients generally come with some foreign body sensation. They're not very vision threatening. Only thing is it's annoying for the patient and for us also. So many times in one of the conferences, actually, I was asked like what to do if a patient keeps coming with episcleritis. I said you always have two rooms, two doors for a room, and go away from the other door. And that's one thing that I keep thinking, that we don't have another door in Shankar about episcleritis, because we don't know what we do with it because it keeps bugging. It's very important that you explain the patient that it is something that is really coming back at him, but it is not vision threatening. If it is recurrent, sometimes it is okay to investigate if it is persistent or if it aggravates, because sometimes a nodular scleritis or a flicken or a tuberculous episcleritic nodule can be there, and which can be picked up by scraping. But scleritis, on the other hand, is definitely one painful and vision and even life-threatening condition. So it can start as something as mild as an episcleritis. It can be a diffuse or a nodular scleritis. It can involve the adjacent structures. So we can have a sclerouveitis and a sclerokeratitis. This is one of the similar slide which Sonshila had shown, that you can have a sclerokeratitis or a PUK along with the scleritis. So scleritis pain is one thing that you will not miss. The patient will keep telling us that he or she has severe pain, and the pain involves the eye and the orbit. It spreads across to the ear, scalp, face. They'll typically describe the pain, showing all the areas. One should not miss the typically dull, boring nature of the pain, and they say that it aggravates by eye movement. Patients have woken up in the night because of the pain interfering with the sleep, and it seems they have had suicidal tendencies. Definitely, you need to rule out systemic association. It's always important to rule out any life-threatening disease. Well, while episcleritis you refer for your sake, this definitely, if it is not improving, refer for the patient's sake to a specialist. Classically, we know that scleritis is described into an anterior and posterior one. Anterior can be a necrotizing and non-necrotizing, but there is a new scleritis score which is not fully into work, and we have the infective and non-infective. So any patient with scleritis, look if the patient. So what do you do? Like, so look if the patient is diffuse scleritis, or if it's a nodular scleritis, or if it's necrotizing or non-necrotizing. So this is the main thing. So one thing to remember is that you ought to know that this there's nothing, there is never in medicine, but you ought to know that diffuse scleritis is rarely infective unless you have some specific characteristic infective features. But compared to diffuse scleritis, nodular and necrotizing scleritis can have more often infective etiology. And once you see scleritis, ask and look for any joint pain, joint deformities, backache, skin rashes, or any other symptoms like sinusitis, renal or respiratory symptoms if the patient has. So before going into the systemic details of looking into the patient's features, you should actually know like what are the etiology of scleritis. It's better to know. It's like, you can call it, you ought to know if you're writing exams, but at least like for the basic clinical examination, at least the top three you better know. The immune-mediated scleritis, rheumatoid, vaginous, you don't call it vaginous any longer. GPA, we call it spondyloarthropathies or SLE, are more often the immune-mediated ones which causes scleritis. An infection in India, anything is TB, at least you rule that out. Fungal, nocardia, viruses, and pseudomonas are other infective etiologies which can cause scleritis. Although collagen vascular disease and autoimmune conditions form the bulk of scleritis and the rest are idiopathic, there are only about 5 to 10% of infectious uveitis, infectious scleritis, but they can be so devastating that you will have to be very cautious about that. So how do you differentiate an immune-mediated or infective? This is something that anybody has to know if you are managing case of scleritis. You start asking from the history, the type of scleritis, the conjunctiva over it, and the systemic association. So, sir, when he was particular that we have to be specifying what one should not miss, then one should not miss definitely an infective scleritis. So in each of it, we'll see how you can pick up infective etiology clues in a diffuse, in a nodular, or in a necrotizing scleritis. In a diffuse scleritis, the conjunctiva over the lesion is boggy, or if you have a subconjunctival yellow tinge, then you're not looking at a conjunctival necrosis, but you're actually looking at a pus point. So remember that a boggy conjunctiva, a subconjunctival yellow tinge, or a pus pointing, then you're probably dealing with an infective. So don't mistake a pus point as a conjunctival necrosis. Conjunctival necrosis can happen even in immune-mediated scleritis, but it's okay to err on the side of a pus point and rule out infection. When you look at nodular scleritis is more difficult to differentiate between an infective and not infective compared to a diffuse one. So you look at all these things: the size of the nodule, the consistency, the number, and so on. So let's see each of them. So any immune-mediated, or most probably, like clinically, if it's a large spherical nodule, if it's firm and hard consistency, something a solid looking. I keep telling our PGs and fellows that if you see a nodular scleritis, which is something like a solid looking hard one, then probably it's not infective. And anyway, you do all the tests to rule out the underlying rheumatological disorders. But if you have a large lesion, large nodule, something with an yellow tinge, or something which looks soft or which you can feel soft or cystic, then probably it's filled with pus, and that is infective scleritis. So a hard-looking one is probably a non-infective one, and a soft cystic one, and which if it is multiple, then it's probably a pus-filled nodule scleritis, which is infective. Many times they are strikingly similar, but they are significantly different. Make sure that you are able to differentiate them. On the other hand, necrotizing, diffuse and nodular scleritis, you can get away, but the necrotizing scleritis is even more scary, because even more important for you to remember that, because it can be even life-threatening. The underlying vaginous granulomatosis can kill the patient. It's tough to differentiate between infective and non-infective scleritis in a necrotizing one. So, but when in doubt, err on the infective side, err on an underlying severe systemic disease. And it's very important that you refer to the specialist early with the necrotizing scleritis. So diffuse scleritis and a non-necrotizing scleritis, probably anybody can treat till the point. But the necrotizing scleritis, I would definitely advise it to be under care of a specialist. When you look at necrotizing inflammation, so about 70 to 95% are immune-mediated, but infective like fungal, nocardia in India, TB, viral, can all be necrotizing. As we were talking about chemical injuries and sins are other cause of necrotizing inflammation, you'll see each of them. So one has to know that if you have a PUK, If you have a PUK along with the necrotizing scleritis, it indicates that the patient is having an underlying systemic vasculitis, which is going to be lethal if it's not treated with aggressive immunosuppressive therapy. So this is an indicator that the patient is having a severe disease. Among the two major immune-mediated diseases, which I would like all of us to know, is about rheumatoid arthritis, which is the most common association of scleritis. Almost one-third of the patients have it. One clue to pick up a case of rheumatoid arthritis associated scleritis is that the patient can have mostly a peripheral keratitis with a whitening like this. They can also have thinning and sclerocorneal graft may be required in when it melts. The other one is the more severe one, the granulomatosis polyangiitis. They can present as severe necrotizing scleritis. Any patient with scleritis, a necrotizing one, if you have a retinal vasculitis or a posterior segment pathology, then you're probably dealing with the case of GPA. The mortality risk is very high in these patients compared to other ones. Do a C-ANCA. If C-ANCA is positive, renal biopsy is obviously the confirmatory one, but still all these suggestive features with the C-ANCA positivity, you are definitely dealing with a case of a GPA, and it means that it needs aggressive therapy. We saw about rheumatoid arthritis and Wegener, but it's better to know about the others too, especially the systemic lupus erythematosus. Usually they are diffuse or nodular one, but in the case of SLE, if it leads to a necrotizing scleritis, again this indicates disease severity and renal involvement. This needs emergency management. The others that can cause scleritis are relapsing polychondritis and all these. So among the infective ones in India, as I said, like you're almost always right. If one of the DD is tuberculous scleritis, so TB, when you look at the lesion itself, it looks something like a subretinal abscess. Somebody who sees the posterior segment more often and enjoys posterior segment more often, then when I see a tuberculous scleritis with a nodule like this, my thought immediately goes up to the fundus. Probably it's looking like this. So maybe the scleritis itself will give you a clue, or the nodule itself will give you a clue whether it is a pus-filled node or not. So it's always better to have a high index of suspicion. It can mimic a subretinal abscess. Scleral TB, you need to treat it as extrapulmonary TB. Full course of ATT has to be given along with anti-inflammatory therapy of steroids. A full course means 9 to 12 months of anti-tubercular therapy under care of an infectious disease specialist. One thing we saw Somshila showing us about the keratitis is also about nocardia. Nocardia can also cause the other acid-fast organism other than mycobacterium, where we see infection in the ocular surface, is nocardia. It is a weakly staining gram-positive rod. It is criminal if you miss nocardia scleritis because we were talking about the facilities available, and Vikas was telling about microbiological facilities available in tertiary care centers and in their terms. If nocardia scleritis is missed, then we should not be forgiving ourselves, because it can be diagnosed by basic lab tests. Nocardia necrotizing scleritis, to scare the cataract surgeons, there has been reports of nocardia scleritis after somebody treated it for cataract surgery, CME, with the subtenols. When you see a fungal scleritis like this, then you start thinking that the patient is probably an immunocompromised patient. So don't miss an immunocompromised state if you are dealing with a candida scleritis. This also be reported. So talking about many sins, like it's very sinful if you forget sins. Surgically induced necrotizing scleritis, when you're seeing a patient with scleritis, as you all know that sins can occur after a pterygium surgery or a retinal detachment, scleral buckle surgery, TRAB or a squint. Inflammation is typically initially localized to the site of the lesion when they use mitomycin or otherwise, but they can also be into the adjacent site of the surgery. Autoimmune disease vasculitic association has been known, and it requires immunomodulatory therapy. As sinful it is to forget sins, it's more sinful to miss an infectious scleritis as sins. So it's always remember that you rule out infection before making a diagnosis of surgically induced necrotizing scleritis. Remember that once I was actually telling one of the patients that since is surgically induced, so he probably thought the surgeon is induced in necrotizing scleritis. It's not surgeon induced, it's like surgically induced. So rule out drug induced and chemical reactions too. This is one of the cases of one of my colleagues, Bhaskar, probably many of you must have seen in his presentations, where the patient had actually used acid in the eye instead of the usual the drops which was originally prescribed. And remember that the tarsal ischemia and blanching is not a feature of scleritis. Scleral nodule is another thing where lymphoma can present as. So imitators masquerade is one thing that you need to be aware of. So looking at what we ought to know, we saw the anterior scleritis, but we should also remember that the scleritis can be posterior or it can be a pan scleritis also. So how does a posterior scleritis present? Posterior scleritis is something that can be missed subtly because the patient will give a vague headache history and pain on ocular movements. You'll see that there is no redness in the eye. The disc edema can be there. Look for subtle ILM folds, and that will indicate that there is some fluid. Look for vitreous cells. Okay, that is very important. And compared to other uveitic entities, posterior scleritis may not have too many vitreous cells. So look for subtle vitreous cells. FFA is very characteristic. The early pinhead leaks with late pooling, and ultrasound may pick up a T sign. So a differential diagnosis of Harada's and sympathetic ophthalmia is for FFA finding like this. But always remember that posterior scleritis can be associated with collagen vascular diseases, and TB posterior scleritis has also been reported, obviously from PGI. Posterior scleritis, what else you ought to know? You ought to know that you definitely need to know that it can present as mass lesion. This is one of the case of giant nodular posterior scleritis, which was reported long time back, which was initially diagnosed as melanoma. And it can be recurrent too. This is one of my patient kid who keeps getting this, and he's on adalimumab and is on very much under control. So this you ought to know. But it's okay if you don't know that we published for these. And finally, investigations and how do you investigate and treat? So for any disease, you have the basic routine, blood routine investigations and CRP, which can be indicators. And a non-necrotizing, if you find a non-necrotizing diffuse scleritis, you do a rheumatoid arthritis factor and A&E. Sometimes we started doing HLA-B27 testing, and not necessary that you need to do it routinely. But if it's a necrotizing scleritis, ANCA is definitely a must in adding to these investigations. If you're suspecting infective etiology, think of TB or syphilitic, and scraping deroofing is the diagnosis more often. And it's good to know that UBM and ASOCT imaging techniques have also been helpful in scleritis. In mild varieties of scleritis, topical NSAIDs and steroids can be helpful. But in severe cases, we generally prefer, in a first attack of diffuse scleritis, NSAIDs or steroids definitely are helpful. Indomethacin is a very good drug, works very well. But if it's recurrent diffuse scleritis or a nodular non-infective scleritis, then definitely steroids. And if it's recurrent, methotrexate is a very good drug. If at all one drug if you think of which you can use in any case of scleritis, which is non-infective, then methotrexate definitely works very well. But if it's recurrent, non-necrotizing, and in necrotizing scleritis cases, methotrexate and mycophenolate combination can be used. But in more severe cases, and if the ANCA is positive, we prefer using cyclophosphamide. But currently, biologicals is probably the answer. And among biologicals, remember that adalimumab, rituximab, and the oral form of the same, tofacitinib, recently there have been quite a few publications on the same on scleritis seem to be showing promising results. And in spite of all this, if the sclera and the surrounding area melts, then probably we send it to the ocular surface people. They do the patch graft, and obviously after the control of inflammation. So remember that it is important in scleritis that you remember that it has varied presentations. It can have diffuse, nodular, necrotizing, or anterior posterior. It can be vision or life-threatening. If one disease of the ocular surface, other than malignancies, if you're worried about life-threatening disease, then it's scleritis. Because it's very important that you rule out you identify the underlying systemic disease and treat it. Immune-mediated are more common. Immunomodulators are the mainstay of therapy, and biologicals seem to be having very good results. But it's very, very important that you ought to rule out infective scleritis. If you miss it, your globe is gone. So treated with specific anti-infective agent after diagnosis and along with steroids. And don't miss, and importantly, don't miss SINs and other masquerades. Thank you.